Okay, and thank you for the kind introduction. As you had mentioned, my task today was to talk about how do we establish a cellular therapy program, and I'll talk about our experience here in the U.S. and I'll try my best to help you translate some of that into what you can think about as you consider setting up something like this in your own institutions in Saudi Arabia. And obviously, I think my friends at King Faisal Hospital and Research Center in Riyadh have already established a CAR T cell program. So obviously, I mean, you all have the opportunity to get guidance and work and insight from them as you think about what might be something that can work in your local context and what might not. Now, these are my conflict of interest disclosures. Obviously, none of them have anything to do with the presentation I'll give today. So in the first two slides, just want to give you a sense of the Sierra Canada network, because some of you may not be familiar with what we do. So we essentially have a network of 11 BMT programs in the US and the UK, of which we have 9 programs that are FACT-AC accredited. And the network was started around 10 years ago. We've done 16,000 transplants so far. And in 2021, we performed a little over 1,400 procedures, including roughly 150 cell therapy infusions through a network of 5 IECT programs or immune effector cell therapy programs in the United States. So as we think about the network, what we have accomplished is, I mean, even though we have these programs in different sites, they are truly integrated. We all try to function as one big transplant program with a standardized quality plan, standardized SOPs, standardized patient eligibility criteria, and we have standardized clinical care pathways for things like conditioning regimen, for GVHD prophylaxis, for supportive care, and so on. So switching gears and talking first about CAR T cell therapy, I keep this brief because I understand we have some really good presentations that are following this talk on how to consider CAR T cell therapies for myelomas, lymphomas, and leukemias. But I think most of you in the audience are familiar about the CAR T cell therapy concept. And as you consider about autologous CAR T cells, the T cells are typically collected from a patient using a lentiviral or a retroviral vector. They are genetically engineered, to start expressing antibodies, which can so they can be genetically engineered to express antibodies against specific antigens. For example, CD19 in the context of lymphoma, or BCMA in the context of multiple myeloma. And then those cells are expanded. There is the quality assurance aspect of the cell product that has been manufactured. And then those cells can be shipped back and infused to a patient following the utilization of lymphodepletion chemotherapy. So again, in very simple terms, this is what a CAR T cell therapy concept looks like. But having said that, as I'm sure many of you know, the whole field is blowing up. I mean, with so much excitement and so much new stuff coming through, we are looking at constructs beyond CAR T cells like CAR NK, TELs and whatnot, which really are going to establish the next era of our cell therapies that we do within our transplant programs, and as well as even outside our transplant programs. Now, since we are talking about how to establish a program, I just want to emphasize here how CAR T cell therapy is very similar to what we do in the transplant space, which I think most of you are more familiar with. I mean, at the end of the day, we are looking at immune manipulation. There is some reliance on chemotherapy, and we use chemotherapeutic agents, which most of us are familiar with. So the typical regimens include Cytoxan and fludarabine. And instead of relying on a donor immune effect, as we do in an allogeneic transplant, we are looking at cells that have been genetically modified to attack a certain type of tumor cell. We all recognize that both are very complex cellular therapies. I mean, they all require a dedicated team that is experienced, understands what they're doing, and understand also the quality aspects of what it takes to successfully do these therapies. And obviously, in that context, we need teams which are well-resourced, well-experienced, and have the background and expertise in this area. Now, this slide basically shows what is out there currently as you think about immune effector cell therapies and what is possibly coming within the next couple of years. Now, if you look at the FDA-approved product, we have in the US at least 5 products that are available for commercial use. So we have Kymriah, or T-cell genlecleucel, which is approved for the treatment of adult diffuse large B-cell lymphoma, as well as pediatric and young adult at ALL. We have exicaptogene cellular, or Yescarta, which is approved for the management of follicular lymphoma, as well as diffuse large B-cell lymphoma. Then we have Liso-cel, or Breyanzi, which is also approved for the management of diffuse large B-cell lymphoma. We have Abecma, or idecaptogene vecleucel, which was approved for the treatment of multiple myeloma by targeting a BCMA antigen. And then, of course, we have Tecartus, or Brexucel, which is approved for the treatment of adult ALL and also the mantle cell lymphomas. So obviously, all these products have been approved in the last 3 to 5 years. So it just gives you a sense or a context of where the field is heading. And I think within this next year, we're expecting approvals for Cilta-cel, which is another anti-BCMA product for myeloma. There is active ongoing discussions between the FDA and a company that makes Tab-cel, which is an EBV virus-specific T-cell product. And then we have the tumor-infiltrating lymphocytes, or TILs, as we call them, which are being considered for approval for a melanoma indication. So that would obviously a cell therapy commercial FDA-approved indication in the context of solid tumors, if and when that comes through. And then we have a cord blood expansion product called Amidubicel, which is also going through the FDA regulatory process. And towards the right-hand side of the slide, you can see where the field is heading. So obviously, what we are most familiar with right now is CAR T cells, but obviously there are a lot of ongoing clinical trials that are looking at a variety of constructs, not only for CAR T cells, but other cell therapies beyond that. And to give you a rough sense of what is going on in the field, we have at least close to 1,200 plus regenerative medicine clinical trials that are currently undergoing worldwide, of which almost 2/3 were in the field of oncology. And obviously at our institution, our Sarah Cannon network, there's a huge emphasis on clinical trials and research. And to give you some context of the activity that is happening in the clinical trial area, of the roughly 140, 150 cell therapies we administered through our network, only a third were commercial product, which are listed on the left-hand side of the slide and FDA approved. Everything else was on a clinical trial for a hematologic malignancy or for a solid tumor. So as you think about a cell therapy program, and again, with the background I've presented, hopefully it gives you all a sense that this is where the cell therapy transplant field is heading. So obviously, as a center that provides comprehensive cancer care services, there is the desire and need to have a cell therapy program that you can hopefully establish within the context of your own institution so you can provide this care to your patients. So as you think about how do you structure this cell therapy program within your own context, I just want to put it out there that there are a couple of different models of care that have been put together or proposed as you think about cell therapy programs. The first model, and I think the easiest model, is to integrate that within your own BMT clinical site. So if you have a high-functioning BMT program with all the resources, the team that understands and is well-versed in providing transplant therapy, I believe you can easily integrate a cell therapy program into that framework with the right resources and the right infrastructure. So obviously in this model, the IECT services are integrated within the BMT program, and it's the same team of physicians, nurses, social workers, pharmacists, other clinicians that takes care of transplant as well as IECT and CAR T-cell patients. Then in a few institutions which have a research focus at present, I mean, you can also have non-transplant clinical sites. For example, there might be an institution which is large enough, has a pretty substantial leukemia or a lymphoma program, in addition to the BMT program, that can manage an IECT or a CAR T cell program. And I think as you think about approved products, and we'll come back to the regulatory aspects of what it takes to do CAR T cells and offer these therapies, it often makes sense as an institution, even though you may have a separate team that provides the care for BMT patients and other disease groups like lymphoma or myeloma patients who need these cell therapies. It still makes sense to share many of the administrative, nursing, quality, and regulatory resources to make things more efficient. And you may have physicians and other clinicians that staff BMT and or the IACT program. So there might be overlap, there may not be overlap. Now, the third model, and I think there are probably only one or two institutions in the country that do this, but this might be something to consider as this field evolves, we do more cell therapies, and as we get into the solid tumor space, you can almost think or envision of a department or an institution or an institute that focuses on cell therapies, where you have dedicated leadership that oversees all those areas. But you can have a section that works on cell therapies for leukemia, another section for lymphoma, another for myeloma, and so forth, with their own resources, their own clinicians, their own infrastructure, and so forth. So again, I think these are some of the different models that are out there. If you are a program that is starting to think about CAR T cell therapies, I would highly encourage you to do that within the context of an existing BMT program, because I think that will obviously set you up best for success versus trying to do this in the context of another of these models I've shown here. I think the only exception might be if you are a program that does not have a strong BMT presence, but has a very active lymphoma or leukemia presence or myeloma presence, which has a lot of experience in clinical trials with these cell therapies in that area. But again, like I mentioned before, there are very few institutions that have that expertise. Now, as you think about setting up a program, even in the context of BMT, and as you think about where to start, I would highly encourage you to look at the FACT and JC standards. So as some of you might know, FACT is the Foundation for the Accreditation of Cellular Therapy, which is the accreditation body in the United States that sets the standards and accredits BMT and cell therapy programs that are designed or that desire to provide clinical care as in the standard of care commercial CAR T concept. Their counterpart in Europe is JC, which works very closely with the EBMT. And FACT and JC have standards for immune effector cell therapy. And if you are thinking of opening a program that focuses on cell therapy, and if you do BMT already, I'm very sure you're aware of these FACT and JC standards. And as you think about setting up a program yourself, I think it'll be wise to look at what those standards are, because they do give you a sense of the foundational basic infrastructure that a high-functioning, high-quality cell therapy program needs to have. They talk about the physicians, what their background should be, their advanced practice providers, pharmacists, social workers. What are some of the SOPs, the standard operating procedures you need to have? What are some of the infrastructure needs that you need to have as well as you think about a cell therapy program? Now, obviously, as you think about what might be the right setup for your own institution, besides the FACT standards, besides your own experience as well, obviously there are other things that need to be considered and talked about, including what are some of the regulatory issues that you have to face in Saudi Arabia, for instance. What are some of the reimbursement and payment models, because that might determine how you set up your own program. And then what is the opportunity for research and clinical trials? And if there is the opportunity to participate in clinical trials in the space, I think that is very optimal for a couple of reasons. One, it gives you more financial flexibility. We haven't talked about the cost of these therapies in the US. In the US, just the cost of these products is close to $400,000 or even more. And if you look at the care that these patients need prior to their cell therapy infusion, after cell therapy infusion, and obviously the management of toxicities, you're looking at care that easily costs close to $500,000-$600,000 or more, at least in the US. Now, a big piece of how you structure your program is also the cell manufacturing aspect of what happens, and we'll come back to this a little bit later in our presentation. And as you get into this, I give you a sense of where the field is heading. So you have to be a visionary as you think about where things might go in your own country and your own context, and how do you plan for future expansion and innovation in the field as things come along. In the next couple of slides, I'll just show some of the things that you need to have in place as you think about your cell therapy program. For those of you who do BMT, all this is very familiar to you because this is exactly what our BMT program personnel's, reporting structure, our infrastructure, all that looks like. So again, if you have a high functioning BMT program, you can certainly use that same group of staff, that same infrastructure, the same quality processes to ease in a cell therapy program. So again, you need a multidisciplinary team that knows what they're doing, have experience, and have that mental mindset, on how you evolve and consider these cell therapies. Because again, we've done cell therapies in BMT for close to 50 years. It's just a different variation of what we do. And many of the foundational principles around patient care, around quality, around what we do as a team are very applicable to the cell therapy aspects of care as well. Now, I won't go into this slide in detail, but again, just to highlight, similar to BMT, you need to have the infrastructure in place for cell therapy patients as well, from the outpatient clinic to the inpatient area, pharmacy, radiology, blood bank. I think most of you know all this, that for a high functioning BMT program, you need to have this infrastructure in place to ensure you provide the right care for your patients. Now, as you think about setting up a program, I think you obviously start with an initial assessment to see what your program needs are and what you currently have in place. A big piece is your team experience, their expertise, and their culture. And again, if you have a high functioning BMT program, you hopefully have all of this in place. You'll probably have to add some other personnel and people to get your program ready for providing cell therapies. Some of that will also depend on the volume of patients you see and how much bandwidth do you currently have and what capacity do you have to add on to what you currently do. One aspect of this process, at least in the United States, is what we call the REMS program. So that's the Risk Evaluation and Mitigation Strategies program. It's mandated by the FDA to ensure that the teams and programs that are offering commercially FDA-approved products have the training and the background to provide these therapies safely and in a high quality manner. So obviously there is the effort and the time that is taken or needed to make sure that the team is REMS trained, and then you can maintain those certifications as you go along. Now, as with BMT, I think it's helpful to establish eligibility criteria and your treatment pathways. What are going to be your pathways for management of toxicities? There are guidelines out there, for example, from the ASTCT, the American Society for Transplantation and Cellular Therapy, as well as other professional societies that talk about some of the patient eligibility issues, some of the management issues, and how do you grade and treat toxicities. So again, it's nice to have something established as you start thinking about offering these therapies to your patients. And then you do have to evaluate your infrastructure. So even though you may be a high-functioning BMT program, I think it does involve so getting cell therapies into your existing BMT program would involve looking at what you currently have and how do you reframe that or repurpose that to provide care to cell therapy patients. And as you plan for these therapies as a program, you also have to look at your space, your care delivery models, and figure out what makes sense for you. Are you going to offer these therapies in the outpatient setting or the inpatient setting? Because at our program, we have experience in offering many of these therapies in the outpatient setting. If you offer this in the outpatient setting, how do you come up with pathways where patients can be transitioned to the inpatient setting and admitted for care where it's appropriate? At what grade of CRS, cytokine release syndrome, who gets involved? How do you ensure that these patients get that dose of tocilizumab very quickly and can be transitioned from the outpatient to the inpatient side in a very facile manner? So again, these are some of the strategic aspects of setting up a program that you have to consider as an institution as you think about bringing cell therapy into the mix of your transplant services. And then you obviously have to identify and address gaps. Often many programs will do a quality audit. They will do dry runs as well, where they look at dummy products and take them through the process just to ensure the systems and processes they have put in place are actually working. And then, of course, there are all the regulatory issues. I talked about the cost of these therapies, which ends up being a big barrier. How do you reimburse for them? How do you get paid for them? And obviously, all the contractual issues. If your cell processing lab, your apheresis unit is not a part of your institution, then obviously you have to establish the relationships and contractual aspects of what you do with those organizations. And if you're using a commercial product that is not homegrown or home produced, then you'll have to establish relationships with the commercial vendors like Novartis or Kite and whatnot. Now, one aspect of this obviously is cell manufacturing. Again, there are different models that are being used right now in the commercial FDA-approved space in the United States. This is mostly centered around centers like our centers doing apheresis, collecting these products. They are shipped off to a central production facility that is run by that pharmaceutical company. They produce the CAR T cells, they do the initial quality assessment, and then they ship them back to us for infusion and patient care. So again, I think that is a model that is being looked at many places in Europe as well, and I think that is slowly being rolled out in many other countries as well. Now, obviously, the other aspect is research, and again, I think as you're starting a cell therapy program, if you can do this in the context of clinical trials, that certainly is optimal because one, it helps you get experience in this area, and also helps you start getting the infrastructure in place for your own program as you think about what you do. So in this context, again, you may work with one of these bigger pharmaceutical companies or other sponsors where cells are, again, manufactured within your own area, and then they're shipped off to a production facility. They're manufactured and then sent back to you. I do want to mention here, there are also a lot of clinical trials going on in off-the-shelf allogeneic CAR T cell and other cell therapy constructs and products. In that setting, you don't have to collect cells for that patient at your institution. These are off-the-shelf products that are available or can be produced pretty quickly from a batch of T cells or other immune cells that are in storage. So obviously, it cuts down the need to collect cells, ship them, and it certainly cuts down that manufacturing time that you have from cell collection to infusion, and it gives you the opportunity to treat these patients quicker. And there's a thought that these allogeneic off-the-shelf products may be cheaper because the production costs are cheaper. But as I think, as you all know, in medicine, you look at the cost when you know about it. So we'll have to wait and see where these products go and what they actually cost as and when they come into the commercial space. The other model that is also being investigated is something at the point of care. So in your own institution, there are places which have invested in GMP facilities. For instance, I understand our colleagues and friends at the King Faisal Research Center and Hospital have a GMP facility they've established to produce CAR T cells locally, which are homegrown. I think obviously, if you can accomplish that, that is a good way to look at this. Although the one thing you have to think about is the investment and cost that is involved in both the establishment of a GMP facility as well as what it takes to keep it running in a high functioning fashion as you go forward. And how do you adapt that for program growth as well as the innovations that are coming in the field. Some programs have also used the Clinimax Prodigy device to produce these cells locally within their institution. As some of you might know, the Clinimax device is basically a closed system. It can literally be put on a desk. And if you have the right expertise, the right team, and are able to procure the right vector and so forth, you can produce these cells locally. I should emphasize that this is research, at least in the US, so this cannot be done commercially, at least in the United States, but I think as we go along, this might be a model to consider in some countries where the products might be cost prohibitive from a commercial standpoint, and you may not have the ability to set up your own GMP facilities and whatnot to provide these products. Now, from a patient care's perspective, I mean, obviously,
2 more minutes, please.
Okay, so we talked about patient selection, we talked about toxicities, we talked about the culture of quality assessment and improvement. And one aspect of what you need to do is to think about the regulatory aspects of your cell therapy program as well. We talked about FACT-JC accreditation. I'm sure there'll be some quality or national accreditation in Saudi Arabia to go down this path. And a big piece that we haven't talked about is reporting of data into a national registry like the CIBMTR or EBMT, or for example, the EMBMT in Saudi Arabia. So the last thing I'll talk about is, as you set up a program, as I mentioned, a lot of excitement in the field. For the last 3 or 5 years, we've established that this is where our field is heading, and we'll be doing more of these products as we go forward. And as you think about your program, you also have to think about what are the future aspects of these therapies you have to consider as you plan for your program. So you have to plan for a program that will be caring for patients 3 to 5 years from now, not today. So in that context, you have to keep in mind some of the newer indications coming through. We talked about some of that early on. Again, a lot of excitement in the solid tumor space, although it's still unknown how effective these therapies will be in the solid tumor space for a variety of reasons, which I won't go into today. We will be getting safer products, and we already are. So that means less toxicities, more ability to do this in the outpatient area. We talked about off-the-shelf products as well as how you can do this in the outpatient setting. And in your own context in Saudi Arabia and in the Arab world, in the Middle East, you have to think about what are some of the access cost issues as well as the production issues we have to think around these therapies, and also the quality and regulatory pieces that we've talked about. So with this, I will end, and I thank you for your attention.